Hello and welcome to our Global Advanced Practice session this afternoon. It gives me great pleasure to introduce Kim Williams and Jackie Orwin from Eastern Health, and who are going to give us a fantastic presentation based on their experience of introducing allied health assistance in their social work department and how they've used that to increase the opportunities for allied health professionals to work at the top of their scope. I'd like to start by acknowledging the traditional owners of the land from which I'm joining you today, which is the land of the Arakwal people on the Bundjalung Nation, and acknowledge elders past and present. So it gives me great delight to introduce our speakers today. Our first presenter is Kim Williams. Kim is a physio, has been a physio for more than 20 years, with fairly extensive leadership experience, as well as an associate fellow of the Australian College of Health Services Management. Highly educated, passionate about interprofessional practice, and committed to quality patient outcomes and fostering a positive growth-focused workplace culture. And our second speaker today is Jackie Orwin, who's the Manager of Social Work at Eastern Allied Health. Jackie has been a social worker for 25 years. You must have started when you were about 10, Jackie, and is also an experienced leader. And as we're going to hear today, lots of expertise in innovation. And is also passionate about continuous improvement in healthcare. So it gives me great pleasure to hand over. Are you the first up with your slides, Kim?
Yeah, I'm happy to share and I'll get us started. Thanks, Susan.
Great, thank you.
So Jackie and I would also just like to begin with an acknowledgement of country. So we begin today by acknowledging the traditional owners of the land upon which we're meeting you from, which is the Wurundjeri people of the Kulin Nation. Pay our respects to their elders past and present and extend that respect to any Aboriginal or Torres Strait Islander people with us or watching this session today. So I'd like to invite everybody to just cast their minds back to 2021, 2022. COVID vaccines were finally starting to roll out. Lockdowns were on their way out, which was a big thing for us here in Melbourne because we most certainly had more than our fair share of them. And health workforce vacancy rates were generally really high, not just across Australia, but internationally, including allied health. And ours here at Eastern Health was 17 to 25% across our therapies professions. And we were all exhausted as humans and most certainly as hospital clinicians and leaders. Is it all coming back to you? Quite hard to forget. And so here at Eastern Health, like many organisations across the country at around about that time, we chose to undertake a workforce strategy piece. And so we partnered with our organisational development and future workforce team within our HR department here at Eastern Health, who brought along their expertise in terms of methodology, internal HR and external market data. We started an environmental scan. And like many organisations, I don't think our environmental scan was alone in its findings, which could be summarised as allied health professional shortages, plus increased acuity, increacute complexity, increased patient demand and flow equals a lot of work to do. Sorry.
Grade 3 East.
The joys of an acute hospital. So with many problems to be solved, the question for us as an allied health leadership group was, how do we approach this? Do we do more with less? I know that in health we're very used to taking that approach, but it felt a little bit fatalistic. And so we thought about, well, do we work smarter, not harder? Possibly, but it still felt too vague. We were very tired and it was hard to know exactly where to begin. That just felt too vague. And so instead we launched into one of our first priorities, which we titled Workforce Mix, with the mentality of what got us here won't get us there. But before we could answer that question, we needed to understand where was here. And so it was really important for us to take a look at, in our environmental scan, AHAs were clearly an opportunity and availability was high. And that was demonstrated by the numbers of applicants that we were getting per position that we were putting out into the market at the time. We were getting easily 20 applicants per position for AHAs and only 0 to 3 on average for our allied health professional roles. And within that, not necessarily suitable and the right skill mix that we were looking for. And so then needed to look at our AHA to allied health professional ratio. On average, it was 1 to 10 across the board, but if you got down into more specificity, you could see that for some areas of physio who were very established with working with AHAs, their ratios could be as low as 1 to 5. But then on the other end of the spectrum, we had our speech pathology department that had just one speech pathologist across a department that spans 6 different campuses, and then our social work team, which were over 40 EFT and had no allied health assistants at that time. But we couldn't presume that simply injecting AHAs was the answer. So we spoke to our clinicians and their leaders, and this is what they told us. All of those high levels of patient complexity, acuity, flow and demand, they actually couldn't reach them on any given day. So here at Eastern Health, we take measures daily of not just our met clinical demands of patients that we do see, we also take measures of the patients that are clinically indicated for us within that 24 hours that we don't get to. And so we categorise those under, did they need our intervention to facilitate their discharge in that 24 hours? Did they need our intervention to prevent deterioration, i.e. stepping back up into ICU level of care or needing to return to acute from a subacute bed? Or did they need our intervention today so that they could progress towards their expected discharge date? And so on an average day, despite delivering in excess of 1,200 contacts, we still average 450 to 500 interventions a day that we could not deliver with the professional workforce that we had. In addition to this, our teams were telling us about really frustrating levels and types of paperwork, which meant less time for direct patient care, education, leadership and improvement works. We also here were not immune to what a friend of mine called the senior brain drain. Through COVID, we had lots of really wonderful allied health staff step out into great project and leadership opportunities because they were recognised for how capable and analytical they were. But that meant that we had a very junior workforce on the floor and junior people in leadership roles. So there was a lot of support being needed at the time. In addition to this, and I really hope it's unique to Eastern Health, but I'm not sure that it is, we still in 2025 are running a hybrid medical record. So we have some sites that are still on paper, some parts of some sites that are on EMR, and we only have one site that is fully EMR. And so automating processes to reduce the paperwork burden was not going to be the solution for everyone. What we needed to understand as a leadership group was the nature and amount of patient, bureaucratic, education and leadership work that was happening. Most importantly, where, by whom, and how long was it taking? Enter the Wombat. So our strategic workforce team from People and Culture identified the Wombat as a tool. This is a work observation method by activity timing, an electronic time in motion study method that they could lead for us, and we gratefully accepted their assistance. The Wombat was originally delivered in 2006 to provide a reliable method for investigating the ways in which health professionals' work and communication patterns change following the introduction of a clinical information system within a hospital. What we liked about it was that it can understand multiple dimensions of work, including interruptions and multitasking that better reflect complex work. And that's exactly what we were hearing from our teams. So it's a licensed tool that collects data in terms of direct observational time and motion studies, and it's captured with handheld devices. So we were using iPads that we were putting in the hands of our observers to go out on the floor and watch the clinicians at work. You create a template that can then be tailored. And so for us, we tailored that to the allied health assistant scope of practice to be able to detect what was being done by the professionals and the assistants at that time. You select and train your observers, and it's really critical that you invest in that training so that you get good inter and intra-related data reliability and good data quality. You identify your observation schedule, conduct your observation studies, and software that's included in the licenses supports you to be able to analyse that work. So a key reflection when I've talked about this with our team is that the Wombat is a robust time commitment to get the high quality of data and depth that it offers. So whilst we gratefully welcomed our strategic workforce team to take the lead on this with all of their expertise and just consult with us as they built and undertook the study, what we didn't understand at the time was that our expertise as allied health was really needed, particularly because this tool has been largely utilised in nursing workforces. And so it would have been really valuable for us to have taken the lead when it came to tailoring the template, training the observers and picking the observation time samples that were used in the study. Would have led to us having much higher levels of leadership and clinician trust in the data that we gained out of it, particularly given that they were so significant. So the next two slides are really just to give you a sense of what the dashboards look like and how much data and information you can get out of the Wombat. It was so informative. It had so many great insights in terms of task nature, location, duration, and who was completing the task. So we could zoom right out to an allied health level and have a look at commonalities across the different professions, or zoom right down into an individual profession and grade level at a single site, which was really important for us when we're a multi-campus site. Our profession managers were provided with these dashboards and able to create all of the cuts that they needed to develop the plans in terms of what they were going to action in response to their findings. In addition to that, we're also able to zoom out at an allied health level to create a case study or briefing paper for additional allied health across the EFT in terms of the assistant workforce for everyone. Whilst today's discussion focuses on the AHA opportunities, we've also commenced an admin process redesign piece to release more of our professional and assistant workforce back to care delivery so that they're not spending as much time on paperwork. So what did the Wombat tell us? Well, we spent 500 hours of observed time across physio, OT, social work and speech pathology from grade 1s, 2 and 3. And what we found was that an average of 24.5% of allied health professional time was being spent on tasks that sat within an allied health assistant scope of practice. The range was quite significant in its variation, from 9.59% for physiotherapy, which is a profession that's very established in their working with AHAs, right through to 43.81% for social work. So they were quite big numbers and a lot for our teams to take in. Jackie will talk a little bit more about that later. But also what we looked at that was interesting was the percentage of observed professional time being taken doing admin tasks. And so that the average was 1.6 hours a week, but it ranged from 48 minutes right through to over 3.5 hours. You can just imagine what that must feel like for the clinicians to be spending that much time away from the patients, which is what they truly love. So at this point, with data like this, you might think that it would be really easy to say, well, how we get from here to there is to just substitute AHAs for allied health professionals and get the AHAs easily, and the allied health professionals are already doing their work. The context is everything, and so you can't consider the Wombat data in isolation. You do need to add the context. Yes, there was significant indication for AHA workforce and admin process reform, but daily unmet need that I was talking about before really indicated there was already an existing significant opportunity for more professional workforce. As we mentioned, we had up to 500 occasions of service each day that we weren't getting to. So when we looked at the data together, what we could see was that we needed a total uplift in EFT of allied health, but that perhaps if we introduced AHAs to do that, what we could expect would be a significant release of allied health professional time to be able to get back to more of that top of scope work that was sitting in the unmet demand, whilst not losing any of the activity that they were already doing if we could introduce the AHAs. We knew that the AHAs were already in the market, so we were keen to experiment with what introducing them would impact on in terms of unmet demand, increasing AHA opportunities, particularly where we didn't have any workforce, and increasing our allied health professional satisfaction through greater top of scope work and less drain of that lower scope, which would hopefully help us to retain that really valuable limited resource. So in a moment, Jackie will tell you a tale of exactly this, but before I hand over, I just want to summarise my reflections on using the Wombat tool. So to Wombat or not to Wombat, it is a big time commitment, but absolutely I would do it again, perhaps a little bit differently, but I would most certainly recommend the tool. The insights and the rigour that we've got through this tool have been highly valuable. They've triggered novel, high specificity solutions. And on top of that, they've had really high levels of senior trust. So when we've discussed the findings of this with our executive and senior operational leaders, they have immediately grasped onto the rigour of this and then trusted the data completely in terms of their decision making and support for some of our recommendations, and that's been really useful. However, what I would recommend to do differently is that if you do have the luxury of having a strategic workforce team to work with, or if you're just thinking about wanting to make the time investment within your allied health leadership team, I would really encourage you to think of it as an investment rather than a commitment, because what you get out of it can be really valuable. Allied Health need to take the lead on the template design. That will allow them to make it specific to your environment, and that's really important in terms of trust again and buying into the data and the solutions and actions that come from it. In addition to that, I'd really encourage you to reach out to the team at Macquarie yourselves, have a conversation with them about the differences between the different allied health professions in your workforce and the settings that you're working in. Nursing has a lot of commonality, even though I know it's a very broad workforce, but when you're talking about distinct professions, picking up that nuance, the original time sample that we were recommended was exactly the same for our 70 EFT physio workforce as it was for our 15 EFT speech pathology workforce. And so having the opportunity to go back to the authors of the tool and really get their recommendations in the context of that would have been really valuable. In addition to that, I would also encourage you to consider that the investment in doing the analysis yourselves is well worth it. The results, as you can see, can be really large and can feel quite confronting. So allowing your clinicians and their leaders to really understand what you're talking about, but also to bring in that context that was everything to not making sure that we didn't jump to the wrong solution was critical for us. So at this point, I'm going to hand over to Jackie Orwin, who's one of our Eastern Health social work managers, to tell you about the team's experience in implementing the Wombat actions here at Eastern Health.
Thank you, Kim. So just before we get into the Wombat, about a year earlier, before there was any talk about Wombats walking around the wards, I, as a social work leader, was contacted by a colleague who was working in the AHA workforce project. And she explained that we had received funding for integrated allied health AHAs across our 6 inpatient hospitals. Integrated meant that they were AHAs that worked in more than one profession. So she also told me that the jobs were advertising then and interviews were going to be commencing in a week or 2. And I got off the phone and thought, gee, that's great. We've been given some additional funding, but what on earth is a social work AHA? I've never seen one. I've never worked with one. How was I going to approach this? And how were we as a social work department going to approach this? But anyhow, a couple of months later, we had 2 4th-year or final year social work students who started on casual contracts in 2 of our hospitals on subacute wards. We buddied them up with social work AHPs who could provide them direction with tasks, etc., and provide supervision. And from then we met every week with the AHAs, their site leaders, a social work clinical lead and myself, and literally developed their key roles and responsibilities as we went week after week. Later that year, we were introducing, probably about within 6 or 8 months, introducing more AHAs into our system. But one of the questions that we had was, what does success look like when you're introducing a new workforce into a well-established and long-standing social work service? So what success looked like for us was getting together and working it out as a team and representing our workplace here at Eastern Health. In these meetings that we had each week, we were defining what success looked like for us so that it not only met best practices for AHAs, but also AHPs that they work so closely with. We developed a key responsibilities document, which is really a scope of practice for our AHAs. We didn't want them used sheerly as personal assistants or for admin. We wanted to develop their role and their scope of practice. So it tells us what they do and what they do not do. And one of the things that defines the roles for me is that AHAs don't step into pieces of work where clinical reasoning is required. We developed a competencies framework and a delegation framework. Monash Health had done some work in that space, as Kim mentioned earlier, and so we used our colleagues' learnings from that in our workplace. We developed specific resources for them, like contact lists, etc. Process guides, like how do you do something? For example, we provide bereavement packs and condolence cards to all families who lose a loved one on our palliative care ward, and so we developed a process guides for our AHAs who now carry out that work. Model of care guides. So we had models of care, and for example, we have a clear pathway for patients of ours that are entering residential aged care or the transition care program here. And so what we did was develop an aligned model of care for our social work AHAs as to how they fitted into that pathway. Position descriptions, so we could, we were hopeful that we'd be able to employ more. Interview templates, as well as a supervision and support framework for these AHA staff. But really our goal was to successfully implement these roles into our acute and subacute inpatient services across Eastern Health and at several hospitals. And then along came a Wombat not so long after. And I remember the day that I was sent an email, opened it up and learned that 43.81% of the observed social worker time was spent on tasks that could have been done by a social work AHA. And I actually had a little bit of a panic. What did that actually mean? What I learned moving forward is that it didn't mean that you could have 40 of your workforce AHA and 60% AHP. There was a balance and there were a lot of nuances involved in that. But what we did learn is we just got better, I guess. We learned that it takes time to delegate work from an AHP to an AHA. So anything that's going to take you 10 minutes to hand over, you may as well just do yourself. We got confidence in terms of how we could explore further where our AHAs could support patients in psychosocial areas that we hadn't yet put them. And certainly as our models of care evolved and changed into the future. We knew we were freeing up AHP's time to focus on work that only a qualified social worker could do, and they were therefore supporting more timely discharges, and it was certainly an improvement in direct patient care. We had an opportunity to embed AH roles into our 7-day service. Here at Eastern Health, in some of our hospitals, we have a 7-day service, so there's an opportunity there to look at that. We have looked at succession planning. We've had some of our AHAs that are attracted to these roles because they are final year social work students. We've had qualified AHA staff as well as non-social work profession AHP qualified staff that have come into these roles. We also learned, certainly locally to us, that the tertiary institutions don't have a subject of social work in their AHA courses, and there's certainly potential there if we were growing this workforce to inform that. So I guess we learned that we had done a good job and we were on track to continuously improve how this workforce worked within our system. But we had successes that we really didn't see were coming. And if you could go to the next slide, this is where we've really felt the joy. We have decreased the daily unmet demand within the social work profession across all of our hospitals. So this is clinically indicated for social work, patient care on a particular day. It was up to 150 patients a day that weren't seen by a social worker, even though they were clinically indicated to be seen. We've reduced that over time down to as low as 60 per day, so 60 patients per day. So what that means is we are seeing more patients, a lot more patients that are clinically indicated for social work on any given day. We've improved patient flow and therefore access as well. We have, as I mentioned earlier, a pathway for patients in our hospitals entering residential aged care. And for the piece that social work gets involved to the time that they are discharged to their new residential aged care facility, we managed to reduce the number of bed days from 19 days on average to 15 days on average. So we've taken 4 days length of stay out of these patients on average. This is a reduction of 20%. So it's not only improved quality of care, because we know for our older cohort of patients, we don't want them in our hospital beds any longer than they need to, but we've saved our health service several millions of dollars in doing so. The other thing we've done is that we've improved social work staff satisfaction. So AHAs are now embedded as business as usual. We have 4 staff and they work across 5 of our hospitals. We have site leaders calling us and saying, we need an AHA tomorrow, we want them in our team. It's a flexible workforce, so we can place them where they need to be on any given day, so where they would add the greatest benefit to the most patients on any given day. But it was at a time when we were struggling coming out of COVID. Our staff were fatigued. They were asking for more social workers and we couldn't get them. The workforce, we just didn't have people applying for our jobs. But what we could find was AHAs, and they came in and made quite an immense difference. So we've been able to we've had a decrease in attrition and an increase in staff retention, which has been wonderful for our teams. And also more importantly, we've provided more timely and enhanced patient care. So You know, if a social worker goes and sees a patient and does an assessment and they need to give the patient some resources, but they're off doing another assessment or another family meeting or whatever, the AHAs can go in and provide more timely care. It's more responsive. And so we just think that our patients are receiving a better social work service, certainly since our AHAs have been implemented. So it's been a very positive outcome for us. And we continue to see new successes. We haven't actually finished our implementation at this point. Back over to you, Kim. Thank you.
So I just wanted to finish. We have had 4 different directors of allied health since we started the strategic workforce project here. Sorry. Speaking of more acute and complex patients, we've had 4 different directors of allied health in this role over the last 6 years. So, just wanted to acknowledge those people, but also really want to acknowledge our allied health professional managers here have undertaken this, and at times it's been really bumpy, but we could not have turned this into the goal that we have without their commitment to trying to work out how we can do things differently and achieve a different result. We were struggling for a really long time, but, as Jackie's just described there, we've been able to take a fresh look and do things differently, and that's been through their real courage and commitment and skills and expertise.
Fantastic. Thank you. That's such a great story, and you present it so energetically and enthusiastically. And I know we had some discussion at the start, but I've got a couple of questions. So first of all, you said you don't have any problems recruiting allied health assistants, and you probably don't have any vacancies now. Do you still think that if you were to try to recruit allied health assistants now, you'd be able to get them quite easily?
We're still receiving a lot of applications. I think one of the things that we really like to see a shift in is the TAFE sector and what they're educating and preparing AHAs to come in with. Particularly, I think Jackie can speak more to the challenges. They don't undertake any social work training at all, very little in speech pathology, and we still find there are competencies that we need to add for OT and for physiotherapy. So if we could get to a point where we could get more ready AHAs, work-ready AHAs, then we'd be overwhelmed. But at the moment, we've still got a steady enough stream, and we're now developing in-house our own competency packages to try to upskill people and be able to take on some of those that don't have that full range.
Fantastic. The other thing I was interested in was the task data. You said that Wombat was largely developed for nursing, and you talked about modifying the template. So the things that you showed on the dashboards, were those parameters that you or your workforce branch had to put in? And were those the things that you felt that your staff, your team needed more input into? Is that what you were talking about there?
Yeah, so a lot of the Wombat template that we ended up going with was modelled from both a combination of looking at the allied health assistant scope of practice and picking up tasks from that then we could recognise through the observation, but also coupling it with what we heard from the conversations with the clinicians and the leaders in terms of where were those points of frustration. So it wasn't just the clinical activity we were looking at, it was the non-clinical or the indirect care as well, so that we could pick those things up. Things like, say, for the OT and physios, going and getting a piece of equipment. We've got one building that's 9 stories tall and there isn't equipment on every ward. And so we were able to pick up that kind of information as well so that we could find opportunities, not just related to AHA delegation, that would help us to work out where we could look at process improvement.
And I mean, I know I've turned up with roundtable data back to allied health teams, and they've gone, we don't even recognise this. When you went back with the dashboards, what were the responses that you got from the staff? Did the fact that they entered?
Jackie.
I think so. I was very surprised by the percentage. I did have a guesstimate in mind, and it was a lot higher, but I guess I wasn't really sure how to process it and interpret it. So I think the other thing would be that for our profession specifically, it is highly administrative. So it actually told us what we did know anyway. A lot of the processes that social workers in hospitals are working through are very heavily administratively based. So that wasn't a surprise to us at all.
The other thing I thought was really powerful is the data that you've collected was, the executive valued it and listened to it, because I know, again, I've done so many evaluations and they don't like stories. They don't really like narratives. They like numbers and percentages. So I think that was really powerful. But you said it took a long, it was really administratively heavy for you to collect. You said there was 500 hours of data collected. Was that 500 hours of someone having to collect the data?
Yeah,
Okay.
that was 500 hours of observer time. And so the observers were quite senior. They were generally grade 4s or managers that were out on the floor observing. So it was a really big time and therefore dollars commitment. So that was why I was encouraging people, if you are thinking about using this tool, I would really encourage you to reach out directly to the team at Macquarie University and have the conversation about, look, this is actually the size of our workforce. This is the parts that are homogenous and these are the parts that are not, and then see if they can work out perhaps nuancing the sample sizes in terms of the recommended observation times to be a little bit more specific. That was something that we missed through handing over that piece to the strategic workforce team.
Kim, you've got a beautiful sunbeam.
I do. I'm
behind
sorry.
you.
I've tried to move. I can't get rid of it. I've only made it worse by closing the blinds somehow. Sorry.
You look very angelic. It's all right.
Oh, dear.
Is there a cost to use the Wombat, or is it a tool that you license? How does that work?
Yeah, it's a licensed tool. I think that there is a cost available. Thankfully, that was another benefit of going through our strategic workforce team, is that people and culture picked up that bill for us. So I actually don't have the details.
Look, that's all my questions. Such a powerful story, and I think particularly because you're able to get that level of data. So well done. Is there anything that you want to add that hasn't been covered, or any other points you want to make?
I think one of the things, on a people level, what we haven't touched on today is when you're implementing an allied health assistant workforce, the change management that's required. As I said, we had a very established social work service, so introducing a new workforce required change. Timing was perfect because our teams just absorbed them and grabbed them at full force and trained them up. But it does rely heavily on a workforce that's willing to accept a new kind of colleague and how they're going to align and work with them, etc. I also think that we haven't really touched on how I have implemented a social work AHA workforce, but it's benefited other professions as well, just by sheer, by working alongside multidisciplinary teams. I think that's, something that we haven't really explored yet either.
Thank you so much for your generous time, and congratulations on really such a lovely project. And I could already see we're getting a lot of interest in this. So happy to support you in any way possible to keep disseminating it. Really appreciate that.
No worries. Thank you.
Thank you.
Have a wonderful Easter.